Welcome, everyone. On behalf of RSNA, thank you for joining us today. My name is Dr. Jeffrey Klein, and I will be one of the moderators for today's session. I am a thoracic radiologist at the University of Vermont, the editor of RadioGraphics, RSNA's education journal, and serve as RSNA board liaison for publications and communications. As you work to address COVID-19 in your practice, this webinar is one of the many ways RSNA is trying to reach the radiology community by providing education and resources on COVID-19. You can find these resources on the COVID-19 section of RSNA's website, which is updated weekly and sometimes daily. A link to this page will be provided in the resources panel. Also, as a reminder, this webinar is part one of a two-part webinar series. Part two will be held June 19th from 11 to 12 p.m. Central Time. Registration for part two will open in early June. Now, I would like to introduce Dr. Bien-Sue Tan, who will also be moderating today's session. Dr. Tan is chair of the Division of Radiological Sciences at Singapore General Hospital. He is also a member of the RSNA COVID-19 Task Force. Dr. Tan, I will now hand it over to you.
Thank you, Dr. Klein. With us today, we have Doctors Judy Yee, Kiang-Hiong Tay, and Santiago Rossi. Before we formally introduce the speakers, there are a few things to let you know. You may follow the steps on the screen and in the chat panel to claim 1 CME credit for this webinar. Here's the disclosure and accreditation statement. And the RSNA disclaimer. Please use the question panel to submit your questions during the webinar. This webinar is being recorded and will be posted on RSNA's YouTube page within about 1 business day after this event. Now, I would like to introduce our first speaker, Dr. Kiang-Hiong Tay, my colleague. Dr. Tay is the Assistant Chair of the Radiological Sciences Division of the Singapore General Hospital. He is a SARS veteran and chairs our Radiology Disease Outbreak Task Force for the current COVID-19 pandemic. He's also the current president of the College of Radiologists Singapore. Dr. Tay, please.
Thanks, Bien-Sue, for the kind introduction. First of all, I would like to thank the RSNA for the opportunity to share our experience at this very distinguished forum. SARS hit the world in November 2002. Like COVID-19, it started in China. The epidemic was relatively short-lived, lasting only about 8 months, with slightly over 8,000 cases worldwide. The number is minuscule compared to the current COVID-19 outbreak, where there are now close to 5 million cases worldwide. The case fatality rate of SARS was quite high, at about 10%, which is several times higher than the current COVID-19 pandemic. About 30 countries were affected by SARS, and most of them were in Asia. Countries like Taiwan, Hong Kong, and Singapore were badly hit by SARS, and our responses to the current COVID-19 pandemic have a lot in common due to our past with SARS. The SARS epidemic in Singapore lasted about 4 months. We had 238 cases with a case fatality rate of about 14%. Which was higher than the world average of 10%. 75% of these cases could be traced to 5 super infectors. It was a very painful time for the healthcare community in Singapore, as there was widespread intra-hospital transmission. A whopping 86% of SARS patients got their infections in hospital, and about 41% of all SARS cases were healthcare workers, of whom 5 of them perished. Of note, our radiology department was the nidus of cross-transmission from a SARS inpatient to outpatient, visitors, and healthcare workers. The cluster that is circled on the picture was the result of our hospital dropping the ball, so to speak. This is the contact tracing map of SARS cases in our hospital. Each square represents a case. The blue ones are healthcare workers, the pink ones are patients, and the yellow ones are hospital visitors. Here you can see we could trace back all the infections to one super infector, the case in the red square. You can also see cross-infection from patient to patient, patients to visitors, patient to healthcare workers, as well as healthcare workers to healthcare workers. This is the radiology cluster. The super infector was undiagnosed when he came down to radiology for a barium examination, and he managed to cross-infect 2 healthcare workers, 1 inpatient, 2 outpatients, and a visitor in the common waiting area. Out of those 6 infected, 3 of them actually passed away, and 1 of them was a health attendant from our department. So it was a very painful time for us. This picture on the top right tells it all. In those days, the infection prevention and control concepts were rudimentary or even non-existent. N95 masks, PPE, PAPR were unheard of. We were caught off guard and did not have adequate isolation facilities. Healthcare workers continued to come to work even when they were sick, as this was the norm in healthcare. This has resulted in quite a few clusters. Our radiology department was designed for maximum efficiency and utilization. We serve both in and out patients in the same facility. So there's a lot of mixing between these 2 groups as well as their visitors. So we had to scramble to learn infection control from scratch and on the fly in the middle of the epidemic. We were afraid to move SARS patients around the hospital for fear of cross-transmission to bystanders during transport. So everything is done as portable if possible, and this includes IR procedures. We also segregated the in and out patients temporarily, as we were not able to fully segregate them to different physical locations for some of the modalities like MRI and IR. We had to draw up very detailed protocols as we were very new to infection control. And this is necessary because any gaps in the infection control measures will lead to cross-infection of staff or patients. One of the problems at that time was that large number of staff could get quarantined due to exposure to a SARS patient, and the entire service can be forced to shut down. To avoid that, we had to segregate ourselves into smaller teams so that if one team went down, the rest can still maintain the service. After SARS, our country took incremental steps to strengthen our preparedness for another major infectious disease outbreak. The government introduced the DORSCON framework, which I will expand on it later. There was significant expansion of negative pressure isolation rooms throughout the public hospital system. This includes a purpose-built National Infectious Disease Center, which has 330 negative pressure isolation rooms, which is scalable to 500 rooms. We began national stockpiling of N95 masks and PPE. Infection prevention and control training becomes a compulsory requirement for all healthcare workers, and our government made major investments in biomedical sciences with significant focus on building expertise in infectious diseases. Professor Wong Ling Fa is often referred to as Singapore's Batman, as he was the one who discovered that the SARS virus came from bats. His group was the first in the world to come up with a test for COVID-19 antibodies. The person on the top left picture is our country's chief scientist, and they are working on the COVID-19 vaccine. So we have pretty deep expertise in infectious disease for such a tiny country. DORSCON stands for Disease Outbreak Response System Condition. It was introduced in 2006 and have 4 alert levels. We are currently at DORSCON Orange. The DORSCON framework is just not about medical response to an infectious disease outbreak. It is also about a formal platform to enable a whole-of-government approach, providing strategic and political guidance in areas such as border control, economic sustainability, education, and so on. There is also a communication piece where the general public is updated with the latest information and health advisories. This is an example of education posters created during SARS. As mentioned earlier, infection and prevention control has become a compulsory competency, and all new healthcare workers, whether you're a doctor, a nurse, even the porters and cleaners, must undergo IPC training and N95 mask fitting before they are allowed to start work. The size of the N95 mask after mask fitting is recorded on the staff pass or on the back of their name tags. This has proved to be very useful in this pandemic, as we do not have to scramble to do mass mask fitting just like during SARS. We have about 10,000 employees in our campus, so it's not a small undertaking. Hand hygiene competency is linked to bonus payout, so you can be pretty sure it gets done. We have also built negative pressure rooms for ultrasound, CT, and MRI for scanning of isolation cases. We have isolation rooms what we call fever rooms in our outpatient imaging centers, so as to segregate febrile patients from the main waiting area during disease outbreak situation. Over the span of about 10 to 15 years, with each equipment replacement and renovation, we have managed to completely segregate our inpatient and outpatient imaging, as well as interventional facilities, to separate physical locations. When our hospital built a new multi-story car park a few years back, we factored into the building design to enable converting the car park into a fever screening area for disease outbreaks. Among the various features, a lead line room was actually incorporated into the car park so that we could do portable radiography when the need arises. So we were much better prepared for the COVID-19 pandemic when compared to SARS. Our initial response is largely based on our SARS experience. Our Ministry of Health raised the alert as early as 2nd of January. Our first COVID case was diagnosed on 23rd January in our hospital. He was a tourist from Wuhan, China. We had a few local clusters after that, and DORSCON Orange was invoked on 7th of February. Our initial measures were very aggressive. Many countries were unhappy with us when we introduced border restrictions very early on in February. We had rigorous contact tracing and stiff penalties for those who defy quarantine orders. Unlike during SARS, we now have adequate isolation and ICU facilities. We have no PPE shortage because of stockpiling. Our staff are pretty well versed in IPC measures, and only minor refresher training is needed, mainly for PAPR, as this is not usually used during peacetime. So we managed to flatten the curve, as did some other Asian countries like Hong Kong, Taiwan, and Korea, which have equally aggressive measures. Our second surge came in March, and it was due to imported cases from Singaporeans returning from overseas. These are indicated in the graph, the bars in blue. That has settled, and now we are facing our third surge due to infectious disease in migrant workers' dormitories. It is a huge number, more than 25,000 of them and rising. Fortunately, most of these are mild cases, and they could be managed in community isolation facilities. So our hospital resources are not overwhelmed. Severe cases requiring ICU and fatalities rates remain very, very low. We have introduced what we call circuit breaker on the 7th of April, which is a partial lockdown, and the numbers are finally coming down. Our hospital has managed more than 1,000 COVID cases to date, and there are about 150 of them currently in our wards. My colleagues will address how we deal with the second and third surges in the next webinar in about a month's time. I will spend the few remaining minutes to highlight two things that was different from SARS period. Our radiology division has grown tremendously over the last 17 years, from less than 200 staff during SARS to more than 700 staff currently. Our management team is huge and has 31 members, and it became clear very early on that this team is too unwieldy to manage a pandemic. So we decided to reconfigure our management team to a tighter disease outbreak task force comprising 17 members to handle all COVID-related issues. The framework and format of our task force was modeled after the military, with different members looking after the 4 domains of manpower, intelligence, operations, and logistics. We met daily in the early part of the outbreak as things were fluid, but now we meet about 3 times a week. We follow a fixed agenda as shown so that things don't get missed out. The smaller core group still meets daily in the morning to review overnight events and anticipate major events for the day. We also have a rep in our hospital COVID task force, so we have direct links to our senior management. These are some of the things we go through at every meeting. For example, the manpower status, who are on sick leave, were there any fever clusters among our staff? We also review workload on a weekly basis so that we know where we can redirect manpower and resources accordingly. And this is shown in the bar chart below. Social distancing was not a very developed concept during SARS. It is, however, a key strategy for COVID-19 to prevent cross-transmission, especially to prevent healthcare worker to healthcare worker transmission. To date, our division only have 1 healthcare worker that came down with COVID-19, and she got infected in the community and not in hospital. In our current setting, the likelihood of getting infected in the course of our work is very low due to strong IPC measures and adequate PPE. The infection risk is actually higher in the community, especially since there is now spread from asymptomatic patients. Hence, social distancing is essential to minimize cross-infection. Meal times are the most vulnerable as masks are down, so we advise staff to eat lunch alone or sit widely apart and refrain from chatting during meal times where they are not wearing any masks. So in conclusion, our response to COVID-19 is very much shaped by our past experience with SARS. Many of the measures are harsh or perceived as overkill, but they have proved to be necessary. The Disease Outbreak Task Force framework that we adopted has been useful so far and has helped us also address our 2nd and 3rd surges. This is my SARS slide. Sorry for the fine print. These are some of the COVID publications from our division, and what I have presented are documented in some of these publications. For those interested, I would be most happy to forward you the links to these publications. So thank you very much for your attention. Please take care, keep your distance, and stay safe.
Thank you, Dr. Tay. Our next speaker is Dr. Judy Yee. Dr. Yee is University Chair and Professor of Radiology at Montefiore Medical Center and the Albert Einstein College of Medicine. She is an accomplished abdominal radiologist who leads a large academic department in New York City. Dr. Yee is past president of the Society of Abdominal Radiology and is a well-known leader for multiple organizations. And she is with us today to share her experience with COVID at the epicenter of the disease in the United States, New York City. Judy, welcome.
Thank you. And I'd like to thank RSNA, Drs. Klein and Dr. Tan, the opportunity to share with you our experience in managing a COVID surge in a global hotspot, New York City. I'm chair of radiology at Montefiore Medical Center, which is located in the Bronx in New York City. And as you can see, our first cases came to our largest hospital in early March. And within 4 weeks, this rapidly escalated to about 2,000 cases. And I'm glad to say that as of 2 days ago, we are currently on the other side of the curve, and we currently have about 400 cases. This is the website for the Hopkins COVID tracker map that I think you may find useful. And it can be used to track any country. You can see globally, currently, there are over 5 million COVID positive cases that have been confirmed, with about 1.5 million located in the United States. When you look at deaths globally, there are about 330,000 deaths due to COVID. And of those deaths, about 1/3 are in the United States. And within the United States, about 1/3 of the deaths are actually in New York State. When you look at the map of the US, you can see the yellow arrow points to a clear hotspot centered around New York. Now, New York City is located in the southeastern portion of New York State. Where I'm located, the Bronx, it is north of Manhattan and Queens. There are 5 boroughs. And the Bronx is home to about 1.5 million residents. It's very special because we do have a large Hispanic and African American population. We serve the underserved, so our patients typically have a high burden of chronic disease, such as hypertension, diabetes, and asthma. And as we all know, these are comorbidities that increase the risk for the development of COVID. Additionally, crowding is an issue, and this makes social distancing difficult. These 2 graphs demonstrate the infection rate and the mortality rate by borough in New York City. And you can see that the blue arrow points to where the Bronx is. And basically, the Bronx has the highest COVID infection rate and the mortality rate of all of the boroughs. I think that everyone has noted that there are racial disparities in COVID positive cases. And it's not just in New York City, it's really globally. And this graph shows you that when you look at the case rates for community cases in the hospital and mortality rates, that Blacks and Hispanics by far have the highest rates. What are some of the lessons that we've learned from this pandemic that we are currently still undergoing? Is that you really need to institute aggressive measures early on. You need to quarantine symptomatic individuals and to perform aggressive contact tracing. And in fact, when I showed you in the first slide the early in-hospital admissions, this was related to some of our faculty who were quarantined and a cluster that occurred in New Rochelle, which was just north of where we're located. Now, back then, we did not have adequate PCR testing. So if an individual were exposed to a COVID positive person, they had to quarantine for 14 days. And currently we've decreased that down to 7 days. You also need to strictly enforce social distancing strategies and hygiene and universal masking. We have fortunately developed adequate PCR testing currently, and we have 2 strategies, both on-site and off-site testing. On-site is preferable because the results come back more rapidly within hours now. But we also have off-site testing. That typically takes 2 to 5 days because the samples are mailed out. Another strategy that I think is particularly important is to develop a radiology-specific COVID response team. And this should include your radiologist leaders, so physicians, administrators, nurses, PAs, your technologists, and definitely your IT team. I think this really helps you to more efficiently and quickly deal with COVID-related issues at all of your different sites. There are also site considerations, and we paralleled our efforts relative to our clinical colleagues. So as our elective surgeries and procedures were canceled and deferred to a later date, we found that there was not as much need for outpatient imaging, so we closed some of our outpatient sites. More importantly, with the overwhelming number of inpatients that we were getting, we had to rapidly expand the number of beds. And that included both ICU beds as well as inpatient medicine beds, as well as emergency room beds. And in fact, our children's hospital was converted into an adult COVID hospital. Concurrently, you need to increase your stock of ventilators and then the medications that are used for ventilated patients. Now, how does this affect radiology specifically? Well, we needed, very quickly we realized additional portable X-ray units. We just did not have enough on hand for all of our different sites and for the large number of inpatients. We were fortunate in having close partnerships with vendors who were able to provide us with demo and trial units at no cost to our hospital. We also initially designated specific CT scanners for COVID positive patients. But again, because we had so many infected patients, it wound up that all of our CT scanners and all of our imaging equipment we had to treat as if it were for COVID positive patients. And that's what we wound up evolving to. Ultrasound cases are special because the technologists spend quite a bit of time up close to patients, and we had a lot of infected patients. So we asked that a physician triage all ultrasound cases, meaning that they would decide whether the case was even indicated to be performed. And if indicated, they would make sure that we decrease the number of images that were needed so that we only needed to answer the diagnostic question. And this slide just shows you how we were able to, within 4 weeks, transform our grand hall into a COVID ward. And you can recognize the pillar, but pretty much everything else was converted. The flooring was changed, and COVID patients were quickly able to come into this ward. Now, I did want to spend a little time going over with you the American College of Radiology recommendations for imaging of COVID patients. And basically the recommendations state that CT should not be used to screen for or as a first-line test to diagnose COVID. If, however, you're in an area where there are constrained resources, where you have limited availability of COVID testing, for example, some practices are requesting and using chest CT to help make decisions. Portable chest X-ray should be used only when medically necessary. The CDC parallels the ACR recommendations, does not currently recommend chest X-ray or CT to diagnose COVID. Below you see the chest X-rays of an unfortunate 27-year-old woman in our hospital who had no significant past medical history. You can see came in, was intubated, has bilateral pneumonias, and did not do well. I also wanted to bring to your attention the new Fleischmann Society consensus statement that has subsequently been developed. These guidelines state that imaging is not routinely indicated as a screening test for COVID in asymptomatic patients, and is also not indicated for patients who have mild features of COVID unless there's a risk for disease progression. However, imaging is indicated for patients with moderate to severe features of COVID, irrespective of the test results for COVID, and it is indicated for COVID patients who have an evidence of clinically worsening respiratory status. An additional lesson learned is that you do need to stockpile PPE. And this is the list of the typical PPE that is needed. We went on to Amazon, for example, even to purchase goggles, which were still available. Surgical masks are typically not an issue. Gowns and gloves and disinfectant wipes we didn't have an issue with initially. What we did have an issue with were the N95 masks and the face shields. And we're fortunate in that our health system rapidly was able to develop supplies of N95 masks in coordination with the other New York hospitals. Face shields, we were fortunate in that we had just opened up our 3D imaging lab with multiple 3D printers located in the lab. We started to print our own face shields. And we have since disseminated thousands of face shields to the entire health system. Now, one strategy we also used is that you'll find within the pandemic, your research labs are closed. And pretty much only employees coming in to take care of animal labs are allowed in. For those labs that were closed, they were very generous and lent us their PPE that they were not using. So we received PPE from them as well. And then obviously donations from other sources. I bring your attention to this paper that was published in JACR, which details a lot of what I discussed. We enforce that all patients to and from radiology must be masked. And this is just an example in the lower left of the surgical mask and the N95. And typically N95s are used once and then disposed of. There is an option for extended use, which is what we're doing, where you can wear the N95 throughout the day. You place a surgical mask over the N95 mask, and then if you're patient facing, you also put in a face shield, and this has worked very well in protecting our frontline healthcare workers. And this is just an example of the thousands of face shields that we have printed in our 3D imaging lab. We found also that there was a shortage of nasopharyngeal swabs for PCR testing. So our 3D lab started to print these swabs as well. Now, another strategy we used is remote reading. And I think that this is something that many sites have started to use, particularly during the pandemic. It's been extremely helpful. We divided our radiologists into two teams. 30% read remotely from home and 70% remained on site. Our interventional radiologists were the only ones who stayed on site, all of them. Our off-site faculty shifted their weekly coverage, so instead of Monday through Fridays, they were asked to cover Wednesdays through Sundays. We were fortunate in that about half of our faculty already had home workstations because our health system did not have the funding to provide to purchase new workstations. For the radiologists who stayed on site, we practiced strict social distancing, and we only allowed 1 or 2 radiologists per reading room. We're fortunate in that we have multiple sites spread across the county. So many of the radiologists were able to have their own room, and that was very helpful. Resident education is critical to maintain during the pandemic, and so we allowed residents to read from home or on site. They were paired with an attending based on the division that they were assigned to, and were able to continue to look at clinical cases actively and to continue to learn. We also instituted lectures and e-learning successfully. There are personnel considerations also. And as we experienced a significant drop in our volumes to about 60 to 70% within 6 weeks, we found that many of our divisions did not have enough work. Interestingly, the only divisions where we had stable workload were chest and interventional radiology. And as our surgical colleagues deferred and canceled cases, some of our IR cases increased. So for example, our interventional radiologists were putting in a lot more gastrostomies and catheters. We did provide for our faculty who were not able to come into work because of various reasons, medical reasons, for example, reasonable accommodation and FMLA. We also shifted vacation and academic time and front-loaded that so that when we do expect a surge of increase in imaging volume later in the year, we'll have more faculty on hand to help with that. And then as a health system requirement, we were asked to redeploy staff. And on the eligible list were our residents and fellows, our faculty, our PAs and nurses. About 50% of our residents wound up being deployed to COVID wards. And I am extremely proud of how they handled themselves in multidisciplinary teams and did very well. Our faculty were eligible for deployment, but as we decreased in case volume, they were never asked to actually be actively deployed. We did deploy some of our nurses and our PAs. I think staff support is important throughout the pandemic, and our health system jumped in. They provided no-cost hotel nights for the frontline staff who were worried about going home at nights and infecting their family members. They also provided, you can see, car rentals and hospital meals and scrubs. And then our medical students pitched in and helped provide free child care. Staff well-being is also critical during the pandemic, but also after the pandemic. And new support centers were developed. You can see emotional support hotlines, expedited referrals to psychiatry, clergy for spiritual support, and all of this is continuing. Now we are on the other side of the curve, as I mentioned. We've developed our post-pandemic planning, or P3 task force, as I like to call it. And these are the specific areas of focus. We are developing what we call our designated care sites, where specific COVID positive patients will go to specific sites. We're performing optimized scheduling, so we're not immediately going back to full schedules. We'll have fewer cases with rest times between the cases so that we properly clean, disinfect the equipment. We are streamlining protocols, such as for MR, to decrease the length of exams. We are looking at social distancing with our waiting rooms and reconfiguring seating, as well as making sure that we have proper distancing markers and signage. Continuing education for infection control, specifically for radiology, is being developed, and we are performing strict inventory control of our PPE going forward. I think in trying to gain and regain the confidence of our patients and our referring physicians, messaging and public relations is very important. So we're using text messaging, developing multilingual videos for our patients, and using social media to reach out to our patients and referring physicians. Something that we started to use during the pandemic, and I think that will continue, particularly because it is reimbursed within the United States, is use of telehealth consults, specifically for interventional radiology and neurointerventional radiology. But perhaps it can be extended to other areas like lung cancer screening. And then finally, research is a big part of what we do, and we have not opened up on our Einstein campus research labs as yet, but I expect that to happen within the next few weeks. So this image just shows you how many patients we've actually had in our hospital. This was a discharge of our 5,000 COVID positive patient just about 2 weeks ago. If we are to learn from history, specifically the 1918 influenza pandemic, that came in 3 waves. The second wave was actually much worse than the first wave. And I think that all of the lessons that we've learned, the best practices that we have developed, will certainly carry on for the expected next wave, and hopefully it won't be as bad as expected. With that, I'd like to thank you for your attention.
Thank you, Dr. Yee. Dr. Santiago Rossi will speak next. Dr. Rossi is a thoracic radiologist from Buenos Aires, Argentina, who works at both private and public environments. Dr. Rossi, please.
Hello, thank you very much to all of you. And I'll try to address how low-resource countries prepare for COVID-19. The first thing we need to address is that South America is a big continent where there are lots of heterogeneity in their population. And that's one of the main problems that we are addressing with this pandemic disease. As an example, I can tell that Brazil is the 3rd country with most cases with COVID-19 after the States and Russia. And also another thing that we need to address, that there is some heterogeneity in the amount of tests that we are performing in our continent, leading by Peru with almost 22,000 and Chile tests per million. And that's important in order to also establish the numbers of cases that you're seeing positive in our region. Argentina, it's been locked down since May 20th, and we have actually more or less 9,000 confirmed cases with 470 deaths. And what's one of the benefits we have is the benefit of the hindsight. We know what happened in other continents, and we can at least prepare for the spike of COVID-19. As we see here, Uruguay has flattened the curve, and we see that Argentina started to flatten the curve, but then suddenly starts to spiking. We think that we're going to have the spike in a couple of weeks from now, and as we're seeing in some other countries of the continent. Argentina, as lots of South American countries, have an heterogeneity population. And here you can see the Patagonia. That's a very nice place. I bet you that most of you know Messi and Buenos Aires. That's a very nice city. But what's one of the problems we have? That the poverty rate is almost 36%. So we have a lot of the population confined and with social vulnerability. In order to we need to be address this problem in order to contain COVID-19. Also, one of the problems we have, as we've seen in lots of the countries, is to take care of the nursery homes. We have more than 7 million people, more than 60 years old, and we, as a company, we're trying to do PCR in lots of them in order to help them to isolate patients when they have positive cases. We also, as Latins, we need to change habits. We drink mate, that we share between all of us. We usually do barbecues, and we always try to gather. And that are habits that we need to be changed from here to the future. There's also something that we've been seeing in the last couple of weeks, that the cases started to be more popular in the mid to high social scale, and now there's been a spike of low income society patients, and that's where we are seeing now. As a radiologist, I work in both the public and the private hospitals, and both of them are trying to prepare themselves in order to attend this COVID issue. As our institution, what did we do? We first, more or less in March 12th, we developed a task force. Then we thought in how to transform and adapt our organization to what was coming. And we developed also communication channels, just as email, WhatsApp groups, and Zoom. We did a lot of Zoom or Teams or any conference website. And we decided that our main issue was to do continuous training. In Latin, and as in many other places in the world, we had a medical supplies difficulty. So our main objective was to get the most of our supplies in order to be aware of what was coming. And we stocked a lot of supplies in order to address this pandemic. And what was our decision was to move fast and firm, transform and adapt our organization. At the beginning was an initial shock because we had to reduce our volumes, do biosafety and biosecurity norms, and also we designed group leaders and training groups. One of our main objectives is to keep inform our organization. And I think that in Latin, that's very important to have group leaders and also inform all our organization. And also we started, like the other groups that we heard before, to do home office, reports from home, and staff rotation in order to keep our staff safe. We also learn a lot since, at least in Rossi, we have 2 labs that we do PCR and antibodies. So we learn a lot from biosafety from them. We did a 360 learning network between the lab and imaging, and that helped us a lot in order to understand and also do crossover of information between both places. That was really an important key because we learned a lot from the molecular point of the COVID-19. From the patient's experience, we decided to communicate a lot to our patients and to community. So we communicate symptoms, forms of transmission, prevention, how to wash your hands. So we did a lot of social media to help the community to understand what we were going to have in our society in the near future. Another thing we did was also protocols to how to arrive to your house, how to take care of your sons during quarantine, and also recommendations how to travel in public transport. So we did a lot of communication in order to help our patients, not just as an imaging or as a clinical point of view, but also through the lab and through the communication to their day-to-day life. In our setting, we need to move very fast and build panels to temperature, social distancing, washing hands. So, and also one thing that we did is to give exclusive time schedule for elderly patients in order to go to the labs. Another thing that I think it teaches a lot for the future is the training experience. We created a video chat training capacity module where we train everything, and we help our technicians and physicians how to change themselves their biosafety PPD in order to be more safe and gave them more support. We also learn a lot from our lab technicians in order how to take biosafety measures. And here we have some of the images of our training and also how we gave them the PPE mask and safety devices. We also think that it's very important also in countries like us in Latin America to do community outreach. We teach them how to do face masks. We did a stay-to-home campaign. We put all our people in our 3D printing in order to donate masks to a lot of the public hospitals. I think one of the issues that we have in Latin is the medical devices and how they can reach the public hospitals. I think that's something that we as physicians and sometimes as leaders, we need to help them in order to get more devices or in order to help them to work in this pandemic situation. We donated a lot of masks, a lot of 3D masks to policemen, gardeners, and also to some public hospitals. We work with some companies that help us with acetate to build masks and 3D printing that say stay at home. And that's something that we did from our institution. One of the main things that we also think that's very important in Latin is to educate and communicate. So we did a lot of webinars regarding imaging, how to work as an imaging department, also as a lab, in order to how to understand the molecular test of COVID and when to use them. And also we came out in some medias in order to talk to the people and try to educate them and give them some advice of how to do the test and when to do them. To finish, we also created a platform that's a COVID control board where we are adding all our PCR results and all our imaging results in order to mix them and have a bit of information to take decisions in the future when this COVID spikes a bit more and when we as an institution need to make some decisions. Before ending, I'd like to say that the most important thing as leaders in radiology is we need to try and teach and educate and do continuous training to our technicians, administratives, and doctors in order to give them more safety in their day-to-day work. Thank you very much.
Thank you, Dr. Rossi. We have some time for question and answers. And I would like to encourage the audience to type in questions, and Dr. Klein will have a look at the questions and select some questions. I'm going to start off first by asking a common question of all three speakers, and I'll ask them to answer in turn, and then I'll hand over to Dr. Klein. So question I have for all three speakers is, looking back, what is the one thing that you or your department would do differently in preparing for this first wave? So can we start with Dr. Tay?
Yeah. Earlier in my talk, I mentioned about reconfiguring our management team into a smaller task force and adopting a military format. I think if I were to do it differently, I think I would bring forward this military format a little bit earlier. I mean, in the early phase of the pandemic, things were quite fluid. Information was lacking. Decision need to be made fairly promptly. There was little time for discussion. Information, instruction needs to be disseminated in a coordinated manner. A lot of these pieces are akin to a military operations. And I think we have a conscript army in our country. So the males are fairly familiar with the concept. And in our department, we were fortunate to have staff who had held senior positions in the military before. They were used to fast-paced kind of operations, and they had been useful in helping us with the framework. And I think that has served us well so far and has also helped us address the second and third surges. So I think, yeah, I think if I have to do it again, I would bring forward this model earlier in our response. Yeah.
Dr. Yee?
So looking back, I think what I do differently, it would be to assure PPE preparation. I think there are downstream consequences when you're not fully prepared, and I don't think we were fully prepared at the beginning of the pandemic. It's obviously critical for patient safety, but staff safety as well. And when you have staff who become COVID positive because of lack of PPE, that has consequences as well. And so making sure that our staff are adequately educated in donning and doffing PPE is also necessary, because even though you have adequate supply, not everybody puts it on and takes it off correctly, and then they can self-infect. It was such a cause of anxiety and stress at every level that included, from our clerks to our technologists and nurses, physicians, trainees, and if we had proper, I think, PPE preparation, that would have decreased that a lot. It led to staff calling out sick, and actually because they were sick, and some were just frightened. I think having a strict inventory and creating a process where, we have 4 hospital sites and 11 outpatient imaging centers. So now, we keep strict inventories that are controlled. Having accurate site tallies will definitely help us, I think, for the next wave when we expect it to occur.
And Dr. Rossi?
As Judy was mentioning, I think that one of the areas where we learned a lot, and I think we need to put a lot of emphasis, especially us in Latin, that we are in this moment at the spikes of this COVID-19, is to take care of our staff, especially of the healthcare workers. And I'm lucky that I work with my brother, who's also a radiologist, and he's taking care of all that. And I think that a good training is what I would continue to do in order for the next couple of weeks, where I think we're going to be struggling a bit more.
Great, thank you. We have, I think, a few minutes left that we can pose some questions to the speakers from our audience. So let me begin with this question from Sean Pierce. I'll pose this question to Dr. Tay. Dr. Tay, his question is there a role for COVID-19 testing for patients coming to your department? I think specifically, will patients be required to receive any testing prior to image-guided radiology procedures in your department?
Currently, we don't do that. Although specific for interventional radiology, the answer is no. There are, however, some surgical procedures, especially the transplant, where I think in their protocol, they have requested not only testing, but also a CT chest of the patients before undergoing major surgery. So I think in our setting, the test, which patients get a PCR, there's a set of criteria, basically a risk stratification. And if a patient is low risk and so on, we don't test the patient. I guess we focus on social distancing, PPE, appropriate PPE, adjusted to the level of risk. Yeah. So we don't do testing.
Great, thank you very much. Another question from Diana Stillwell. Let me pose this, if I can, to Dr. Rossi, who is a thoracic radiologist. What percentage of patients do you think will require follow-up imaging after they have recovered from COVID pneumonia? Because I think we know that there are probably likely to be chronic lung issues, particularly in patients with significant comorbidities. But do you have any sense for what percentage of these patients who survive the infection will require some type of evaluation and follow-up imaging afterwards?
I think that's a very interesting question. I think that we're going to learn a lot from this, and especially from this transformation from organizational pneumonia or fibrosing to this fibrotic changes that we think they're going to have in the future. I think that it's going to be a small percentage, since it's going to be the percentage with more critical lung affections. I think that the ones that are going to be mild, or I think those ones are not going to need a follow-up, especially from imaging. I think that with the 2 PCRs, at least in Argentina, negative, and if they feel okay, they're not going to be follow-up. I think we're going to follow up the cases that have distortion of the lung with organizing pneumonia. I think that's going to take us back to H1N1, where we follow up some cases that had injuries in the lung, and we did the follow-up to see how they evolved in with the future.
Thank you so much. This question from Dharmashi Barte, and I'll pose this to Dr. Yee or anybody who has had experience. Have any of you had experience either in your department or perhaps from your pulmonary critical care faculty using chest ultrasound to evaluate critically ill patients?
That's a good question. Our pulmonologists do perform that on a limited basis. We don't do it in radiology. So I think the experience has evolved during this crisis. So not everybody was comfortable with diagnosing. I think pneumonia from pulmonary ultrasound got a lot more experience very quickly. And the preference, though, I can tell in speaking to some of my pulmonologists, still to use portable chest X-ray. So I think it has limited use currently in our institution.
Great. One last question, I think we have time, is from Vivek Kalia. How are you, Judy, I'll ask you this, how are you balancing the need to ramp up your services to non-COVID patients with the need to be prepared for a possible second surge in New York City of COVID patients?
It's a really good question. It's very timely as well, because we just opened limited services, imaging services this past week. And so as opposed to Dr. Tay, we actually, for interventional and neurointerventional radiology services, we are requesting and requiring PCR testing 48 hours before. And we have formed a team where they will be called with the results, and we'll have to check the results. It's a lot of extra, I think, work, but that is what we're requesting. This will definitely be phased in, and we've already opened up some screening procedures, but in a very limited fashion. I think that we have to monitor very closely any outbreaks. Right now, we have minimized the amount of patients that we're actually bringing in, and really not many are sitting in waiting rooms. So we're trying, for example, curbside registration, electronic means of registration, so that very few patients actually sit in the waiting room. They can wait in their cars or wait elsewhere in alternative spaces, and then we'll call them in when they're ready, and they're really just shepherded straight into the exam room.
Thank you so much.
Yeah, it's a very, I think, careful rollout, and with proper PPE. So every site we ensure it has proper PPE for the patients and for the staff.
Thank you, Judy. So I'd like to close by thanking my co-moderator, Dr. Tan, and today's faculty for obviously sharing their expertise. And thanks to our audience for attending today's webinar. Please look in the resources panel for details on how to earn CME for this webinar. Also, I encourage you to continue the conversation on RSNA's new community site, where your radiology colleagues and RSNA leadership will comment and answer questions on issues related to COVID. Please see the chat and resources panel for the link to the site. Thank you, and please stay safe.